right, as folks join in here, I think we'll get started. Good morning, everyone, and welcome to the SCD Summit 2023. My name is Dr. Madeline Verhovsek, and I'm the medical director of the adult side of the McMaster Hemoglobinopathy Clinic, where I work with pediatric and adult healthcare professionals to deliver care to patients with sickle cell disease, thalassemia, and other inherited red blood cell disorders across the life spectrum. I will be moderating today's session on racism and microaggressions in the health system, what patients need to do. If you or members of your network would like to refer back to the information shared in this session, a recording of today's session will be posted on our website, which is the SCD website, for viewing at your convenience. And in this session, we'll be hearing from Dr. Ewurabena Simpson, who I will introduce shortly. Our agenda today will start with housekeeping rules, which will then be followed by presentation from our guest speaker, followed by a Q&A session. We ask that you save your questions, thoughts, or concerns until the latter portion of our session, where our guests will be able to answer questions individually. We kindly ask that you respect the learning being done in this space by abiding by the following housekeeping rules. Your microphones have been disabled for the duration of the webinar. If you'd like to ask a question, please do so by putting your question in the chat or Q&A function or by raising your hand. We'll try our best to answer all questions at the completion of the presentation. There is translation captioning provided. You can listen to the session in your preferred language by clicking the show caption at the bottom of your Zoom screen, checking the enable translation checkbox, and choosing the language you want the caption to be translated into. Note that the session has to be in recording mode before the translation caption button can be utilized, and that's where we're at right now. Number 3, please use respectful language in the chat, no profanity or inappropriate images or posts, please. And please do not post other material unrelated to today's discussion topic. We'll keep the discussions and comments on topic as much as possible. The SCD does reserve the right to pause the session or to seek removal of participants who do not abide by these rules. Thank you for your understanding and agreement to positive participation. And with no further ado, I'm delighted to introduce Dr. Ewurabena Simpson. Dr. Simpson did medical training at McGill University and Hospital for Sick Children in Toronto. She also has a master's degree in public health from Johns Hopkins Bloomberg School of Public Health. She currently works in the Division of Hematology Oncology at the Children's Hospital of Eastern Ontario in Ottawa. Dr. Simpson's major clinical and research interests focus on health systems improvement for children and adolescents with sickle cell disease and other hematologic disorders. In her role as Assistant Dean for the Office of Equity, Diversity, and Inclusion at the Ottawa Faculty of Medicine, Dr. Simpson aims to strengthen faculty-wide approaches for supporting a diverse community of learners, staff, and faculty, and to prioritize principles of equity, diversity, inclusion, and belonging. Provincially and nationally, Dr. Simpson serves as a board member for the Black Physicians Association of Ontario and is also treasurer for the Canadian Hemoglobinopathy Association. I can't think of a more amazing and well-qualified person to give us our presentation today, and I'll hand things over to Dr. Simpson.
Thank you so much for that very kind introduction, Dr. Verhovsek. And so I'm just going to share my screen, so if you could let me know if it's appearing as it should.
Looks great.
Okay, perfect. And so the way that my screen is, I can't see everybody, or I can't see all of my co-panelists, but please let me know if you have questions. I'm happy to answer them at the end of the presentation. So thank you so much for this opportunity to be here. So as you heard, I'm Dr. Simpson, and I'm a pediatric hematologist at CHEO. And this morning, I'll be speaking to you about racism and microaggressions in the health system and what patients can do to counter them. So I wanted to start with a land acknowledgement, and I'd like to acknowledge the opportunity, responsibility, and pleasure with which I endeavor to serve the children, youth, and families of the unceded territories of the Anishinaabe Algonquin people in the region we also know as Ottawa. So I don't have any relevant disclosures, but I do have a disclaimer. When speaking about racism and microaggressions, these are often difficult and potentially traumatizing subjects to discuss. So in this presentation, there's no intention to lay blame or to point fingers, but rather to foster conversations and to validate the lived experience of those individuals who've been affected. So there are 3 learning objectives. I hope that by the end of the session, you'll have a better ability to describe the relationship between social identity and privilege, to define microaggressions and recognize when they occur in healthcare, and also understand allyships and its role in counteracting microaggressions. So to start us off, I wanted to talk a bit about social identity. So as you can see on the slide, social identity is defined as the perceived membership within certain social groups based on specific physical, social, and/or mental characteristics. And we all have social identities. So these may be chosen or born into, they may or may not be visible, and they could be static or even fluid and changing depending on the situation we're in. The hierarchy of our social identities is determined by society, which means that the ranking of groups and the importance of specific differences will be determined by forces outside of ourselves. Each one of us will have multiple social identities, and these identities will connect and interact in different ways, depending on the environment that we're in. And the importance or prominence of any given identity may change depending on the situation that we're in and who we're with at any given time. Race is an example of social identity. So in this photo here on the left, Lucy and Maria Aylmer are from Gloucester in the UK, and they say that when they walk down the street, they're mistaken for just being friends. But amazingly, they're actually twins, even though Lucy appears to be white, while Maria looks black. Marcia and Millie Biggs are also twins. Their fathers of Jamaican descent and their mothers of English descent. Similarly, James and Daniel are also twins. And so it's truly fascinating that this is even possible, where in each one of these cases, one twin has a skin tone that would be considered to be black, while the other looks white. Now, what about privilege? So speaking about privilege, by definition, this is something that's unearned. It's defined as a right or benefit that's given to some people and not to others. And it's an advantage that comes with certain social identities and not to individuals from other social groups. So these unearned benefits are determined by our society. So again, by forces outside of ourselves, and they're based on the ranking of identities and differences that I spoke about earlier. So when we speak about having privilege, it's not the same thing as being spoiled. Being spoiled is rather defined as an individual level trait where a person has an impaired character or disposition because they're excessively lavished, praised, or indulged without necessarily recognizing it. When we speak about privilege, this is a systemic advantage that will benefit one social group while undercutting another. And most of us will have individual social identities that will grant some privilege relative to others, but because we're multidimensional and we're complex as human beings, we may also have identities that make us relatively underprivileged. So coming back to racial identity, it's important to recognize that this is something that can be fluid. And although an individual may self-identify with a specific race, this can be different from the race that they would classify themselves as on a closed-end survey, from how they're classified as or observed by other people, and from their actual phenotype or from their ancestry. So the figure on the right is based on American data, where some 6.2 million US adults reported being of 2 or more races. And this is a number that's increasing in the US as well as in Canada. And for many people, racial identity is not something that's static, but it's fluid. So I wanted to show a video, but firstly, just to reiterate, whether we care for this or not, the racial identity that we're assigned to have by society will be assigned with certain social privileges and status, or it can be associated with oppression. And so from a very young age, Black Canadians will experience the impacts of those overt and often hidden biases. And so I wanted to show you a short video to capture some of this experience. So hopefully you can hear the audio, but let me know if you can't.
Good morning. How are you?
Cool.
So, Can we talk about how you got here?
You think I got a funny looking face? I just thought it was funny.
Hey kids, I'm telling you, go right here.
Man, we ain't doing nothing.
Go right here before I'm called cops.
So, you didn't do anything?
Nope.
Then what's all this?
Depends on who's reading it, I guess.
Well, looks broken. Skateboarding, huh?
Yes.
Is this the first time you've hurt yourself?
No, I get hurt all the time.
At home?
At home. He hurt himself skateboarding at the park.
Okay, ma'am. I'm gonna have a counselor come in and speak with you.
A counselor? For what? He's okay.
Well, I done told you them tricks were gonna put you in the hospital.
I'm sorry.
I'm sorry, too. A nurse will be in a few minutes to help you check out.
What's up?
That doctor thought I did this to him.
How you doing?
Hi.
It ain't fair.
Fair has nothing to do with this. This is about you taking responsibility for your actions. Look, I know so many young men just like you that didn't do anything. And yet, most of them are in prison.
You don't know me. I ain't going to no prison.
If you don't want to end up in prison, you're going to have to get some new priorities and probably some new friends, too. Look, you're not getting any younger. You need to get an education so you can get a good job.
Like you just like everybody else. You think you see, but you don't see. You see what you want to see.
I see what's in this folder. It shows me what you've been doing.
I ain't doing nothing.
Okay, so I'll stop the video there. So you can see clearly from this video that stereotypes and bias have colored the youth and experience of this young boy, but has also affected the experience of his family, others around him, and even the social worker that he's speaking to. And so these are biases that can be covert or they can be explicit, and they're powerful enough to create and limit privilege in society. So what exactly is bias? So bias is defined as a tendency, inclination, or prejudice towards or against something or someone. And so this means that some biases can actually be positive and helpful, but biases are often based on stereotypes rather than actual knowledge of an individual or circumstance. Like this young man was saying, people think they know him and they decide things about him even before asking him or talking to him. And so when it comes to bias, whether they're positive or negative, they cause prejudgments, and this can lead to discriminatory practices and differences in health outcomes. So when we talk about levels of bias, bias can operate at different levels in society. So it can operate at individual and systemic levels, and this will create and limit power and opportunity between socially constructed groups. So when we talk about bias at an individual level, a person's beliefs or actions actually create a storyline. And this is a storyline that is based on our own personal experiences, and it could be conscious or unconscious, and it may be internalized or externalized to perpetuate discrimination. So this storyline will influence the way that we receive clinical care as patients and the way we deliver care as healthcare providers. And it also affects the way that we identify with and interact with society. At an interpersonal level, when we talk about bias, this actually shapes our interactions with others, and it determines how we treat people who are similar to us and how we interact with those who are different. At an institutional level, for example, in the hospital, our biases will inform policies and rules that enable and limit opportunity within hospitals, medical schools, and other institutions. Finally, structural level bias or systemic bias is the broadest and arguably the most challenging form of bias to tackle. And so this is a summation of the effects of bias and discrimination across institutions and across history. So you've probably heard of unconscious bias. So just to review briefly, so unconscious bias is a type of cognitive bias that has an important effect on the way that we interact with people. And as healthcare providers, it can impact the way that we deliver care. As patients, it'll impact the way that care is delivered to us. And so as you can see on the slide, it's caused by associations or attitudes that will reflexively alter our perceptions and thereby affect behavior, interactions, and decision-making. So this means that by definition, unconscious bias is automatic and outside of our awareness or control. So whether we want it to or not, unconscious bias will be created by our own personal experiences, our context and privilege, and it influences the way that we process information. Although we may consider ourselves to be open-minded and unbiased, unconscious bias may actually conflict with or contradict our conscious attitudes. And it's something that we have to be very intentional about to suppress in certain circumstances and situations. The truth is that we all have unconscious biases and none of us is immune. So as I was saying, we have to be intentional to identify them and to reduce the influence that they have on our decision-making and interactions. There's a growing amount of evidence that shows that in spite of their best intentions, our best intentions, healthcare providers and professionals have the same levels of unconscious bias as the wider population. So when speaking about race-based bias or racism, racism is defined as a belief that race is a determinant of certain human traits and capacities, and that these racial differences are meaningful and produce an inherent superiority of one race over another. When talking about systemic racism, this is an interaction between prejudice and power, and it leads to the systemic oppression of certain individuals and communities so that other communities are advantaged socially, economically, and politically. So Dr. Verhovsek mentioned that another hat that I wear is Assistant Dean for EDI. And when speaking about race and racism, this isn't just talking about diversity and inclusion. We're talking about differentials in power and privilege that lead to oppression of certain races relative to others in society. Unfortunately, when speaking of bias, including race-based bias, in medicine, these types of biases can lead to unintended disparities in healthcare access, patient care, and opportunities. And so I want to go through a few examples. So in a recent study, looking at Hispanic patients presenting to the emergency room with pain, it was found that patients who were of a Hispanic descent were 7 times less likely to receive opioid treatment for severe pain when compared to non-Hispanic patients with similar injuries. When this study was duplicated in Black patients were similarly less likely to receive these treatments. So there was a follow-up study that was done to see whether or not this had to do with bias or whether or not the physicians were just not able to quantify pain in individuals who are Hispanic compared to non-Hispanic. But the follow-up study showed that these physicians could in fact accurately judge the pain severity, but they still provided less pain medication to Hispanic patients and Black patients with severe injuries. Another study looked at something called the implicit bias association test, which is a test that measures the degree of bias related to certain social identities, including race. And it found that emergency room physicians who took this test had moderate pro-white and anti-Black biases. And so for this study, this test was taken prior to their shift and after their emergency shift. And it was found that cognitive stressors like overcrowding and high patient loads, which are the norm in every ER across Canada right now, would actually make these biases more pronounced. So you can imagine the impact that this would have on patients if they happen to present to the emergency room during peak time periods. So when it comes to patient care, healthcare provider bias can cause patients to have poor adherence to our recommendations. It breaks down our communication with patients because they're less likely to trust us, and patients may become disengaged, which amplifies disparities in health outcomes. Studies have shown that Indigenous and racialized patients are more likely to believe that they receive more respectful treatment and better medical care if they belong to a different racial group. A recent systematic review also showed that unconscious bias contributes to medical errors. And in a study of 20 publications involving nearly 7,000 physicians, approximately 36 to 77% of errors could be attributed to unconscious biases. So it's clear that bias will erode trust between the provider and the patient. It increases errors in care, and it also disadvantages individuals from negatively stereotyped groups. So if you ask most people, we don't want to behave in ways that perpetuate bias or stereotypes. However, in spite of our best intentions, there could be time where these biases come out inadvertently through our language or behaviors. So this video is a shorter one than the last one, and it comes from a Harvard theater production called I Too Am Harvard. And some of the expressions and stereotypes and statements that are mentioned in this video may have been unintentional, but they are harmful. And these are statements that many racialized people with and without sickle cell disease have been subjected to, even within our healthcare environments. So I'll play the video.
Do you speak African? Aren't you from the hood?
Wow. Can I have your hair?
So your dad's the black one, right?
Why do you talk like a white girl?
What do you mean you can't play basketball?
You speak Spanish, you're not black. Why are you such an angry black woman? Can you even comb your hair?
Dance with me. Is it true what they say about black guys? Hey, what sport do you play?
I thought you were just black.
Why do you act so black?
Hey, girlfriend.
What country in Africa are your parents from?
Call me Poppy. Oh my gosh, you're so pretty for a dark-skinned girl. Can I see your ID?
Tell us the black perspective.
And so think about what you just heard, different labels, assumptions, and stereotypes, and some were probably more hurtful than others. And some of these statements were subtle, others were not, and it's possible that none of them were intentional, but these are all examples of microaggressions. So microaggressions are defined as everyday verbal, behavioral, or environmental slights, snubs, or insults, whether they're intentional or unintentional, that communicate hostile, derogatory, or negative attitudes towards stigmatized or culturally marginalized groups. So microaggressions can be on the basis of any social identity, including race, income, social capital, physical ability, gender, and other characteristics. So when we talk about microaggressions, there are three types. So they can be classified as micro insults, micro assaults, or micro invalidations. And I'll go through each of these to give some examples. So micro insults are often unconscious remarks that will demean a person's social identity or heritage. So here are some examples of statements that many racialized and minoritized individuals in Canada may have experienced. Other things I've heard are comments or questions like, did you get your job through affirmative action? Your people must be so proud since there's so few of you in medicine. And then the next category is micro assaults. So these, in contrast, are often explicit verbal or nonverbal attacks that are meant to be hurtful through name calling, avoidant behavior, or purposeful discriminatory actions. And so some examples of this came across in 2019 when President Trump posted inflammatory tweets calling on Democratic Congresswomen Alexandria Ocasio-Cortez, Ilhan Omar, and Rashida Tlaib, as well as Ayanna Pressley, to go back to where they came from, even though most of them were born in the United States. Trump actually called on these women to apologize and alleged that they were hateful of America just because they were women of color. The last category, or micro-invalidations, are comments or behaviors that will minimize or deny the experience of someone from an underrepresented group or community. And this is often done unconsciously. So here's some examples. So at the top, all lives matter. So this slogan was associated with a rejection of the ideas that's supported by the proponents of the Black Lives Matter movement, and is equivalent to saying there's no problem with Black lives. Others are some comments that we heard in the Harvard video. I don't see color, you don't look disabled, you don't seem like you grew up poor, she's a great woman scientist, or criticisms that men may receive for being stay-at-home fathers or caregivers. So microaggressions can be hard to conceptualize as they often don't seem aggressive. And another term that you may have heard to describe them is subtle acts of exclusion. But the bottom line is that microaggressions are harmful. They serve to reinforce existing privilege and to undermine a culture of inclusion. And so they may seem harmless, but they actually have severe consequences. So when talking about working and learning environments, they can impact one's mental health and make them feel unsafe at work. And as a result, they can have chronic stress and even physical symptoms that can need medical attention and management. If you're in an environment where you're exposed to microaggressions, it's hard to feel like you belong. And then you start to doubt your own confidence in your abilities, which can turn into poor performance or quitting and dropping out of school. In the clinical environment, it causes our patients to lose trust, and it can also lead to individuals not seeking care when they need to. And so if they continue without being addressed, microaggressions will remain ingrained in our culture, as individuals may come to see them as being acceptable and continue to perpetuate them in our everyday interactions. So how can we respond to microaggressions? So in reality, the most common responses are to ignore them, pretend they didn't happen, because they're awkward and uncomfortable, and we often don't know what to say. We may brush it off either as the victim or as the person who committed the microaggression because it wasn't intentional, so maybe it doesn't need to be addressed. Even though the words are hurtful, we may always assume positive intent as though that carries more weight than the words themselves. But in reality, the intent is not as important as the impact of the microaggression. And in the words of Maya Angelou, people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And so if we focus on the intent rather than on the impact, we're actually continuing to privilege the person who committed the microaggression. And in doing so, we actually increase harm that's already being caused. And so we need to focus on the harm that's been committed and how to make it right. So the best responses to microaggressions will actually increase your awareness of microaggressions and also insist that people stop committing them and call them out when they do. So this is easy to say, but how do we actually do this without putting ourselves at risk? So we can respond later, we can walk away, reflect, compose ourselves and think about how to come back and address it. Or should we respond immediately in the moment and call out the person for their behavior? Or should we let it go? Depending on the circumstance, any one of these responses can be appropriate, but I'll just go through a framework that's really helpful to actually provide a structured response to microaggressions. So this is a helpful framework that was developed by Ella F. Washington and Allison Birch and Laura Roberts, and was published in the Harvard Business Review in 2020. So this framework helps to determine which course is best in any given situation, and it's called the Discern, Disarm, Defy, and Decide framework, and tries to help to direct you to respond in certain ways to a microaggression. So I'll go through the framework. So the first column or the first type of response is by discerning and reflecting on the situation to determine if you really should respond to a microaggression. And so this really depends on how important the issue is to you and how important the relationship is to you. Because if either or both are important, then avoidance is definitely the wrong thing to do. Your feelings are also important in the moment because microaggressions can make you doubt the legitimacy of your reactions. Like, am I overreacting? Is this really as bad as it feels? But really, you should let yourself feel what you need to feel, and any emotion is legitimate. And it also factors into your decision to respond immediately or later, because if you're very triggered and you feel that you're going to be angry, the best thing could be to take a step back before coming back to respond. And then the other thing to consider is how you want to be perceived now and in the future, because there will be consequences to speaking up, as there will be to remaining silent. So if the issue is important to you, then you really should speak up, because otherwise it's going to happen again. So the next arm of the framework is disarming the perpetrator of the microaggression. And you can do this by using phrases that invite them to sit along with you in that awkwardness of their words, and helps you to get to the root of their behavior. So you're reframing and reflecting the statements back to them. So you can do this by acknowledging the feelings behind the statements. So you can say something like, it sounds like you're really frustrated or nervous or angry, or I understand that you're upset when you feel disrespected, but this is what your statement feels like. Another way is to express your feelings directly. When you touch my hair, I feel like you're treating me like an animal, and I'd like you to stop. Another way to disarm someone who's committing a microaggression is by sharing your process. I notice that you like to talk about women and the way that they dress. I used to do that too, but then I learned that that's actually really offensive, or it really takes away from how smart the woman is or how accomplished they are, for example. So in doing this, you're showing them the impact of their words. Another way to disarm a person is by using humor. You don't want to minimize the microaggression because it's something that needs to be called out. But sometimes by using gentle sarcasm, you can show an individual how awkward or silly their statement may be. So for example, you said she plays like a girl. Do you mean she plays like Serena Williams or Mia Hamm, if we're talking about soccer? Another way to disarm somebody is by promoting empathy, putting themselves into your shoes or the shoes of the individual who is feeling the microaggression. So for example, how would you feel if someone said that or did that to your sister or girlfriend? Or I know you don't like stereotypes about women, so how do you think he feels when he hears things about men that are negative and generalizing? So these are a few statements that you can use in the moment to try to make the person sit with you and to reflect on what was said, because sometimes we don't realize the impact of our words. Another part of the framework is to defy the microaggression, and this is to challenge the perpetrator to actually clarify their statement. And you can do this by asking probing questions, like, for example, what do you mean by that? Or why did you say that in this instance? And in questioning them, you make them really think about what they said. And this actually gives people a chance to check themselves as they unpack what happened, but it also gives you a better opportunity to gauge their actual intent. So one way to do this is to pretend you don't understand. I don't understand why that's funny, or I don't get what you mean by that. You can ask for clarification or more information. So could you say more about what you meant by that, or how have you come to think that? And in doing so, you're actually making the person reflect on what they said and try to justify it if they can. Another way to defy a microaggression is to appeal to the values and principles of an individual. So if you know somebody is really passionate about equity, then you can say so and say, for example, I know you're really passionate or you really care about equity and inclusion, but actually by acting in this way, you're really undermining that and those values. Another way that you can defy a microaggression is by pointing out what a person has in common with the other person that they're actually stereotyping. And here's an example of an instance of Islamophobia and Islamophobic jokes. So you can say something like, I'm tired of hearing your Muslim jokes. Did you know that he's also studying music and likes to play the piano? You may want to talk to him about that. You actually have a lot in common. But sometimes you just have to be direct and remind them of the rules and policies of the institution and of the environment you're in, because sometimes, these small pushes may not be enough, and you need to remind them that these are just not behaviors that are accepted where you are. So by telling them that their behavior is against a code of conduct and could get them in trouble, that could be a way to remind them. But anytime you're using these questions or making these statements, you want to avoid why questions, because you don't want to increase defensiveness, but really speak from your perspective to try to show the individual how their statements and microaggressions are landing and the impact that they have. Finally, the last step is to decide what this instance will mean to you and your life and your work, and what you'll take from the interaction and what you'll allow it to take from you. Because this also is important in deciding to respond to a microaggression, because it's a way of protecting your well-being without allowing microaggressions to bring you down. So each time we don't respond, we're allowing these to persist and further harm us going forward every time we come back to an environment that enables microaggressions or interact with an individual who commits microaggressions. So I've shown you 2 videos, and now I just wanted to tell you a short story from my past and my experience as a medical student and resident. So this particular story comes from my time as a resident, and it was a day on the ward, and our team was in the middle of rounding when we were rounding on one of my patients. So in this instance, the parents would not address me and would only address the male attending physician who was standing in the background. But in this case, instead of answering the questions that the parents were asking him, the attending physician was very clear, and he said, "You'll have to ask Dr. Simpson. She's an excellent physician, and she's the resident in charge of the team." In that moment, and with that statement, this attending physician stood up as my ally, and this small but powerful sentence made a huge difference for my relationship with the patients, their family, and with our entire medical team. When speaking of allyship, this is something that is so important to facilitate equity, inclusion, and respect, and to counter microaggressions and race-based discrimination and other forms of discrimination in society. Allyship will come as a result of active self-reflection to mitigate bias and to help to advance the interests of those who have less privilege. So as an ally, you'll need to stand up for others and to speak up against microaggressions and against race-based stereotyping. And looking at your peers and colleagues, we all come from a mosaic of differences, and being an ally means understanding and respecting those differences. So allyship is about having someone's back. It's a continuous process of advocacy, support, and being a voice for people whose voices aren't being heard. So this means that it's something that's active, and an ally recognizes their own privilege and uses that to support others with less privilege. So this is a framework that comes from the University of Toronto Faculty of Medicine that I really liked, and it talks about how you can address microaggressions as an ally. So it uses the CARES acronym, where if you as an ally inadvertently commit a microaggression, or you're a bystander that sees a peer who's being subjected to microaggressions, you need to consider how that is harmful. You also need to be accountable for your own actions and willing to apologize in the event that you accidentally or inadvertently committed a microaggressions. And then the R stands for rethinking harmful assumptions and going forward and reflecting on your own unconscious biases when you interact with people from different groups. E stands for empathy and empathizing for those individuals who are receiving microaggressions. And then finally, as an ally, you support those individuals by offering resources and asking how you can help, and also by standing up and speaking against microaggressions. The reality, though, is that sometimes these effects or these efforts to confront microaggressions may not always be effective, but it's not your responsibility to change or educate someone who's harming you. And there are actually processes in place that can help to support you in getting institutional support beyond yourself. And so if you're experiencing microaggressions and discrimination, what should you do? In reality, the first inclination, again, is to do nothing, because most of the time, it's hard to believe that the policies in the system will actually help us or that the behaviors will actually change. And then there's a great deal of fear that also comes with speaking out. Fear of embarrassment, fear of being penalized or losing status, fear of being retaliated against and not receiving the care we need, or being blamed, or just not being believed. And so there are actually informal as well as formal procedures that are in place in the hospital that you can rely on to report instances of microaggressions and discrimination and to help you to deal with these instances. So the first thing is to admit that there's a problem. And I think that in many of these circumstances, we often have self-doubt. Is this a situation that's worth reporting? Maybe it's not so bad, but it's important to assume that it's important not to assume rather, excuse me, that the behavior will stop, because it might actually get worse if we ignore it. So if there's situations where you're not sure, maybe that you think that you're over interpreting something, you may want to make a log to actually keep track of behaviors that you find to be concerning, including dates and descriptions of the incidents. And then if you feel comfortable doing so, you can communicate with the individual directly using that discern, disarm, defy, decide framework that I went through. And you can explain what aspects of their behavior have been hurtful or offensive and how it affects you. Other informal procedures that are really important are to talk about this with someone you trust. So it could be a friend or family member, or you can try to speak to somebody on the medical team if this is happening in the hospital. And so this can feel less comfortable if it's the team who's treating you when you're admitted to hospital, but you can also rely on your sickle cell team, your social worker, or even your sickle cell disease advocacy representatives from organizations like SCD, SCD, and other local organizations. Microaggressions and discrimination are really difficult to deal with. So it's important that you seek assistance for yourself by way of counseling or mental health services. And so you can reach out to your social worker or sickle cell treatment team to see what supports are available to you and how best we can help you to navigate this. You may need to escalate this beyond the immediate team, and every hospital will have a patient's relations office, and many hospitals are now having patient equity offices that are specifically there to help you to navigate these situations and to get support, and also to help the institution to do better so that these instances don't happen again in the future. In all of these instances, if you were to seek help through the hospital, for example, your information will be kept confidential. Same thing applies if you approach your sickle cell team or inpatient team, in that our first priority is to protect you and then to make sure that you're well supported. There are also formal pathways for reporting that you may seek to pursue. So for example, you may write a written complaint, and many hospitals have online reporting portals for this. Or again, you may seek help through the patient relations office or patient equity office, where they can advise you about how to formally lodge a complaint against an individual who's committing microaggressions or has behaviors that are discriminatory towards you. In some instances, you may be advised to report the incident to the college if it does impact the care that's being delivered by an individual, so that you would have to speak to the college that governs that specific health profession, may it be a physician or a nurse. Or if it's very severe, you may be advised to complain to the Human Rights Tribunal or pursue charges that may be criminal or civil, but these are extremes, and you would be supported and counseled about how best to do this. So that brings me to the end of the formal part of the presentation, but I have a few take-home points. So firstly, we all have different social identities, and some of these identities come with privilege, while others come with risk for oppression. We all have unconscious biases in spite of our best intentions. And when we speak about race-based bias, we know that in healthcare providers and within the health system, this can impact the way that we deliver care and the way that patients access care and the outcomes related to their health. And it's important that we actively counter microaggressions. So we need a way to respond to them. So you can try to rely on this discern, disarm, defy, decide framework in determining when and how best to respond. But as allies, it's important that we support one another. So this can be your medical team This could be your friends, your peers, this can be the hospital, who's there to support you to help to mitigate and negate the impact and presence of microaggressions in our health system. So that brings me to the end of the formal presentation, but I'm happy to take any questions. So then I'll stop sharing.
Thank you so much, Dr. Simpson. And so this brings us to our Q&A portion of the session. And I'll just remind everyone, questions can be posed through the chat feature or through the Q&A feature within Zoom. All appropriate questions will be responded to in order of receipt, as much as is possible across the different platforms. And please as well know that you're able to raise your hand if there's a question that you'd like to share just by speaking it rather than typing it. So I'll start. We've got a question already in the Q&A, which is fantastic. This reads, excellent presentation. I wonder about whether we need to evolve the term microaggressions. I sometimes wonder if that term diminishes the impact of some of these comments, for example, the Trump tweet.
Right. Yeah. Thank you so much for this comment. And I do agree with you in many ways, because I think, you know, the micro part particularly does seem to minimize how harmful these microaggressions can be. And so I think that, you know, in time, maybe we will change the term and how we describe these events. And I think that many people aren't even aware that this is something that's problematic. And I think there's some truth in that in saying microaggressions, it makes it sound like it's a small and perhaps less meaningful harm. But we all know that these are important behaviors that can have many harms when it comes to healthcare.
Thank you so much. While we wait for some other questions, I really like the way that you pulled apart the microaggressions into those different, the micro insults, the micro assaults, and the micro invalidations, and thinking about it as not really kind of not all microaggressions are experienced in the same way, and some of them can be intentional and some of them can be unintentional on the part, and just kind of adding in that nuance in how we reflect on and respond to. I wonder, recognizing that we've got a very diverse group of people in all ways, I think, attending the summit today. I really like the way that you spoke to both the role of the healthcare professionals in addressing discrimination, bias, and racism, and as well giving some tools for patients of how they might navigate this. One question that I've encountered recently is really, you know, this whole issue of racism or discrimination or bias is self-evident to many of us, and sometimes you encounter folks where there's a pushback. Whether in a professional setting or, you know, in a personal setting. And what are the tools that you most often use to kind of highlight the issues when someone seems to have a low level of awareness or some skepticism?
Yeah, so thank you for that question, and something I've definitely encountered in sessions like this, and even on in more informal contexts where there is doubt about the need, I guess, to highlight challenges like this because we're in an evolved society where we don't see color, for example. And I think, you know, we all know that that's not the case. And I think that it's important to first try to understand the perspective of the person, and, you know, perhaps they haven't had the exposure or lived experience or teaching to really be aware of these issues. But I think really emphasizing the similarly to when I was talking about microaggressions in general, the impact and the outcomes that come as a result of these biases in society, may it be individual or systemic, I think data is really powerful. And so, for instance, if I was talking about medical schools and inequities in admissions, it's very easy to see that there are disparities just by looking at the racial makeup of the class. Or, in Canada, we don't have as much race-based data that's readily available, and this is something that's changing, but it's clear looking at data during the COVID-19 pandemic, for example, that became available particularly in Toronto and bigger cities, where we clearly saw inequities in the rates of COVID-19 and the morbidity and mortality associated. So I think sometimes, just talking about the data and the numbers, which are more difficult to dispute than the impact, the emotional impact of bias and race. I think that's a helpful way to try to educate. But at the same time, sometimes in spite of your best efforts, you're not going to be able to convince everyone. And at the same time, it's not necessarily your responsibility as a racialized individual to teach others. And so that's where institutions and like hospitals and medical schools have a responsibility in teaching and educating our future clinicians, but also in setting policies that don't tolerate that kind of behavior. So yeah, that's a long answer to question.
Brilliantly put. And I'll just add, that multi-pronged approach that uses data, but also kind of storytelling. And I really like that video that you showed. The videos that you used in your presentation were all very impactful. I'm reflecting particularly on the one that unpacks the boy's journey through life and his experiences of racism. And I think sometimes if someone hasn't experienced those themselves, trying to shed light both through data, but also through that storytelling can be a particularly powerful combo. So thank you. And we have a couple more questions here in the Q&A. The first one, this is one of the most informative and helpful discussion on the topic of microaggression in healthcare. Thank you so much, Dr. Simpson.
Thank you.
Have you found good strategies to support patients and families who are navigating healthcare systems with respect to the emotional burden of facing microaggression, and on top of that, feeling the burden to have to help change that status quo?
Yeah, so that's an excellent question. Thank you for that question and comment. And, I think this is an area we definitely have to do better in, where creating safe spaces for our patients to talk about these issues is so important. And so speaking about my local hospital experience, we're working to have a patient family advocacy group specifically for hematology patients and for individuals living with sickle cell disease. And this is something that we've been talking about for some time with our management, in that we need to find a way to make it not only safe to talk about it, but also to validate the experiences of our patients who may not, know what to expect and may come to accept these things as common and normal, for a lack of a better word. But I think that in addition to having those safe spaces, it's not enough to just talk about it, but the institution has to have a way to actually support individuals living with these experiences to report them, but also have policies in place to actually enforce a safe space for not only talking about microaggressions or bias, but also for accessing care. And so, as Dr. Soul had said in his presentation, institutions and hospitals are now more aware and creating different ways to address equity, diversity, anti-racism. But I think we need to push more to actually have meaningful ways for patients to be able to navigate these issues. I hope that's helpful.
Thank you. And one more question here. Some saying she is a woman scientist might seem a micro invalidation to women, but at the same can esteem how women are starring in the science community. How would we appropriately decode such? And are we being oversensitive?
Okay, yeah, thank you for that comment. I think it's an excellent comment as well, and makes me reflect. And, I think it probably depends on the context of the statement, where, in some circumstances, the way that it's delivered or the context in which it's delivered can either be demeaning or supportive. So I think that in talking about microaggressions and the importance being on the impact, I think that it's important to have a conversation like this where, the individual hearing the comment as a woman scientist will reflect on, is this something that I want to talk about given the context, given the situation? Is it actually something that's harmful? Why am I feeling uncomfortable? But I don't think that it's wrong to say that, oh, I noticed that you said woman scientist. What did you mean by that? And I'm just wondering why you emphasized woman. And that can, diffuse the entire situation where, as you're suggesting, they can emphasize that, oh, because they're a woman, I wanted to highlight their excellence. And so that makes the intention clear. But I think that as long as each individual sits with discomfort, those biases set in and assumptions set in. So I think that it's worthwhile to have an open conversation about it.
Fantastic. Thank you, Dr. Simpson, and thank you to everyone who's brought forward your questions and attended this session. We're going to have a poll pop up here. So please, to each of you, we really appreciate your feedback on your experience of this session, and it helps to inform our planning for next year's summit. So once everyone has had an opportunity to review the session, I'll leave that open for a bit here. Any last words you wanted to add, Dr. Simpson, before we close the session and move on through the rest of the day of the excellent lineup?
Sure. Well, I just want to thank everybody again for being here and for engaging. And I hope that this was helpful. And I know our slides will be available through the SCIGO portal afterward. But if you have suggestions about similar topics that we can present to help our patients as well as our healthcare providers to do better in this area and realm, we'd really appreciate that. So thank you all for being here.
Fantastic. All right. I'm going to give the poll one more minute and then I'm going to end it the way that it's set up. It's a time limited thing. So just encourage any of the last few people who haven't had a chance to fill that in to please go ahead and note that there are a few questions in there. Questions 1 through 6. This has really been an outstanding session, Ewurabena. The expertise that you bring from the clinic all the way through to your work at the medical school and in the hospital institution, you really bring a unique set of perspectives that fit ideally in with what the audience, I think, at this summit needs. But maybe I don't want to bias everybody. So
okay. Thank you for that.
That's my opinion. I haven't filled it in.
Okay. Thank you so much.
Excellent. All right. I'm going to close the poll at this point. All right. And I don't know, it's giving us an option to share results. So maybe I'll do that.
Okay.
So we've got a lot of positive feedback from everyone in terms of the rating of the session and the presenter, what folks liked about the subject. And I think this will all be archived for future planning. So thank you again, Dr. Simpson. Thank you to the organizers at SCIGO and to each and every one of you for attending. We'll close off this session and the recording will be available on the SCIGO website. So thanks and take care.
Okay, thank you, everyone.